Yesterday, I was speaking about the role of natural killer cells in multiple myeloma, and my initial data related to the dysfunction that natural killer cells have in myeloma. So as the disease progresses, that the natural killer cells work less well. And this is actually important because they are an important part of how some of our treatments work. For example, when using monoclonal antibodies, ADCC, or antibody-dependent cellular cytotoxicity, is mediated by natural killer cells. So it's important to understand how they work and how they function optimally. And so there are various strategies that can be used to actually make natural killer cells work better in patients with multiple myeloma. I went through some of those yesterday. There's some data that's come out of the COMPASS study being run by the MMRF, that high levels of HLA-E, which is MHC class 1 molecule expressed on multiple myeloma cells, may in fact be associated with poorer prognosis. And this is probably in part due to inhibition of natural killer cells, but also possibly of T cells. And it's interesting that recently some data came out showing that using a small antibody as an inhibitor, like a checkpoint inhibitor, you can actually block the interaction between NKG2A, which is an inhibitory receptor on natural killer cells, and HLA-E on the multiple myeloma cell. And this is something I think in the future that will be very interesting to look at. What I also discussed, however, was the potential role that natural killer cells could play in cellular therapy in multiple myeloma. And I think we're very familiar by now in the myeloma community with the use of CAR T cells and the very exciting data that have been generated, in particular with BCMA CAR T cell therapy. However, I think what's become apparent that despite the extraordinary results really that have been seen in terms of patients at very late stages of diseases getting deep remissions, that unfortunately those remissions are not long lasting, and it's not the same story as what we're seeing in patients with acute lymphoblastic leukemia or diffuse large B-cell lymphoma, where if patients are still in remission at 12 months, they tend to hold on to those remissions. Unfortunately, there is no plateau on the survival curve in multiple myeloma with CAR T cell therapy to date. So while not wishing really to diminish the efficacy and the benefit that CAR T cells are producing in patients with late-stage disease, there are clearly challenges with the administration of CAR T cells. There's issues potentially with toxicity, with cytokine release syndrome, with neurotoxicity. They're not an off-the-shelf treatment. There's a lot of effort gone into procuring enough healthy T cells from the patient to make the product in the first place, and then there's an inevitable delay before the patient gets the product, which unfortunately in some cases can lead to disease progression before the patient has a chance to benefit from the therapy.